Yeah, thanks very much. I'd like to congratulate for this wonderful Congress. It's always fantastic to be with you, and thanks very much for organizing it. It's just great. So the topic is complicated, as you said it. It's about mid-flexion instability and anterior knee pain, but I'd like to call the topic the patella is only the symptom, because we see a lot of patellar resurfacings done for non-patellar problems, and I think we need to keep in mind that the patella is not the problem, it's the symptom in most of the cases. And you can see it on the image on the right side, what happens if you have an instability in flexion on the lateral side, which is quite frequent with the standard mechanical alignment. We can see that. And even some of the new implant designs, they say you can have a lot of gap on the lateral side. Actually, what is happening, the patella is the stabilizer, and the patella gets more pressure because the patella is moved downwards and the femur is moved upwards. And I think this is the key message I like to give you with this talk. So the patella is often overloaded in typical anterior knee pain. You see failed kinematics is mostly the case. This is a 25-year-old female patient, 60 degrees of flexion, had customized PSI instrumentation to get this prosthesis in like this, and you see how it failed. And so this is a devastating case, and to see that the alignment is important, but also the stability is important. Do not just resurface the patella, do your workup, and I think that's important. You need to do your workup, and as you see, the symptoms are above the ground, but you need to dig deeper to get the true reasons. And I think if you have good intentions, you do the resurfacing because it's an easy surgery, you will fail with this patient. So you need to use a standard workup. This is our standard workup. We go through this a little bit faster here because it's a standard workup we do for every unhappy total knee arthroplasty, and I think you need to do this for every case a patient shows up with anterior knee pain. The most important part is that you standardized use stress x-rays, and these stress x-rays give you an idea. But you also need to understand that there are typical pain patterns related to instability issues. So if you have pain at Gerdy's tubercle, you very often see an instability near extension or an extension deficit. So this is actually a sign that you need to look more into instability. Also, pain at pes anserine is a flexion instability sign. Pain anterior and peripatellar with band-like feeling of tightness is more posterior flexion instability. And if you have pain laterally peripatellar, it's a patellar tracking issue. So I think you need to keep these patterns into consideration, and you also can do kamikaze views, and I think this is a very important view to do. You do this in 40 degrees of flexion, you do the PA view, and you have some weight on the leg, and then you see the lift-off. And if you see such a lift-off and the patient has anterior knee pain, the anterior knee pain is not really coming from the patella. So then do your stress x-rays, and sometimes when you do your stress x-rays, you're very surprised how these stress x-rays look like. You have to do it for AP and also for lateral, and here you see an insufficiency of the PCL in a CR prosthesis, which is quite common. And then you also have anterior knee pain because the patella is overloaded. So we can consider anterior instability and posterior instability, and they are very frequent. So they can be in the early flexion, but they can also be more in deep flexion. But the consequence is the same. You overload the patella. The patella is the symptom and not the cause of the problem. So then you need to understand the rotational issues. We heard from my previous speakers about it. If you have internal rotation issue, you need to take this into consideration. And it doesn't help, as you can see here, to resurface the patella. If you resurface the patella, at the end it fractures because there's still overloading and the pain is still there because the patella is only the symptom and not the problem of this case. So instability issues are more common than we think. We think we are better surgeons than we are actually. And so I think you need to really look into anterior knee pain and instability for these patients. There are many kinds of instabilities. I'd like to show you some how you can address it. So you can address the flexion instability while actually using more conformity in your implants. You can go but you definitely need to change the implant at the end. If you see that, you need to know what the curvature of your femoral condyles is, and then you can address it with an offset system. And it doesn't matter which offset system, but it's the best I can see is the 360, and you should have all options at least to 4 millimeters, but most of the systems offer you now 6 millimeters offset. So I'd like to show you some cases. So this is a patient with a combined problem. You see there is a sagittal problem because the femoral component is too large, the femoral component is flexed, the joint line is raised, the patella is pushed downwards, and you also see a rotational issue of the femoral components internally rotated. This is a ligament balancing system with Mattes prosthesis, and what it happens, they started with the tibial cut, and at the end they went into massive internal rotation, and so this is the consequence. Over time the patella goes down, but the patella again is only the symptom, is not the reason for the pain. You do all your measurements, you see 11 degrees of internal rotation, and the consequence is the patella is overloaded. So what you do, you reconstruct the joint line, you correct everything, and then you end up with a more happy knee. So case 2, 56 years old female patient, 5 years after primary TKA, anterior knee pain, typically feeling unstable on stairs, no night pain. You see what the consequence here is. You see a lateral flexion gap opening asymmetrically, so you do your stress x-rays, and then you also see that the tibial component is shifting posteriorly, so there is a PCL insufficiency. The consequence again is overloading of the patella, and you need to correct this to make the patient happy. If you only resurface the knee, the patient won't be okay. So coming to the end, I think with all these cases, you have to have your specialized diagnostic algorithm. You need to run through this. The patella is often only the symptom and not the cause. Simple secondary resurfacing will not do the job, and it's often an anterior posterior or flexion instability we are dealing with. Thank you very much.